Good morning, respected judges and other delegates. I am Dr. SREELAKSHMI from Jubilee Mission, here to present about ocular toxicity of daily antitubercular treatment regimen, a prospective observational study. So India carries a significant burden of tuberculosis, which is the commonest cause of infectious disease-related mortality. Antitubercular drugs are among the commonly used drugs which can cause serious ocular toxic effects. Since antitubercular drugs are given in combinations, it is difficult to delineate which drug is causing more ocular side effects. This is a revised National TB Control Program daily fixed drug combination regimen, which is currently followed, which involves 2 months of intensive phase and 4 months of continuation phase. In contrary to the previous regimen, ethambutol is used throughout continuation phase also. So, toxic optic neuropathy are a group of medical disorders which can be defined as visual impairment due to optic nerve damage by any toxin, and antitubercular treatment induced optic neuropathy is of the toxic type. Aim and objectives of my study: to study the changes in visual parameters in patients on ATT, to analyze the OCT-ONA changes in patients by taking RNFL measurements once before the initiation of treatment and once during the ongoing treatment, any time between 3 to 6 months. Study design is prospective observational study set in Department of Ophthalmology and other departments in a tertiary care hospital. Sample size 26 study subjects. Inclusion criteria: all patients with microbiologically confirmed and clinically diagnosed active pulmonary and extrapulmonary tuberculosis before starting the regime and while on regime, males as well as females between 18 to 60 years of age group, OCT signal strength more than 6/10. Exclusion criteria include pre-existing optic neuropathy or retinal pathologies, media opacity other than incipient cataract, pre-existing visual field defects and color vision anomalies, history of taking any other non-antitubercular drugs known to cause ocular toxicity, glaucoma patients and antitubercular treatment dropouts. My methodology: patients were subjected to detailed ophthalmologic evaluation once before the treatment and once during treatment. Visual acuity is done using Snellen's chart, which was later converted into logMAR chart. Color vision using Ishihara's chart. Slit lamp anterior segment evaluation and fundus evaluation using 90D lens. OCT average nasal, temporal, superior and inferior RNFL measurements were noted. Mean age of the study subjects were 42 plus or minus 13.71. Out of 26 study subjects, 9 were females and 17 were males. So visual parameters were studied in 52 eyes of 26 subjects. No significant change was observed in visual acuity and intraocular pressure during my follow-up period. Using paired t-test, significant RNFL thinning was detected in superior, inferior and temporal quadrant. No significant change was detected in the nasal quadrant. So this is a graph plotting the RNFL thickness, in which we can clearly see the RNFL thickness has reduced during treatment period. So this is a OCT of a patient prior to initiation, and following initiation we can see thinning in different quadrants. So red-green color vision defects were also observed in 8 out of 52 eyes. My observations: despite a near normal appearance of the fundus on ophthalmoscopy, OCT clearly demonstrated and quantified the loss of retinal nerve fibers from the optic nerves. Based on the study, among 26 samples, statistically significant thinning was observed in superior temporal and inferior quadrant. However, RNFL changes in nasal quadrant was not statistically significant. Red-green color vision abnormalities were noted in 8 out of 52 eyes, and identification of color plates tended to be worse in patients with thinner temporal quadrants on OCT RNFL analysis. Visual acuity and intraocular pressure did not show much significant change. Asymmetric loss of nerve fibers were also noted from both the eyes in majority of study subjects. Discussion: retinal thickness can be measured for early detection and diagnosis of retinal pathologies, and OCT, which is a non-invasive method, has been extensively used to quantify RNFL defects in patients with antitubercular treatment-induced toxicity. So in a study conducted by Zollmiller et al., considerable loss of fibers from all the quadrants, especially temporal fibers, were seen, which is consistent with our study. As Seeskumas et al., thinning of RNFL is seen after 2 months of ATT compared to the baseline values. Yogyukum et al., in that OCT, they showed that OCT may be helpful in follow-up of patients with toxic optic neuropathy. And our study showed OCT changes appeared before the fundus changes, so it is definitely helping in follow-up of patients with toxic optic neuropathy. SM Konakorden et al. Showed out of 40 eyes receiving ethambutol, color vision was defective in about 35 eyes, while in our study only 8 out of 52 eyes showed color vision abnormalities. Since RNFL thinning can be detected before the appearance of clinical symptoms, it helps in early detection, follow-up, management, and it can help in preventing permanent visual damage. It is imperative to create awareness about the oculotoxic effects of antitubercular drugs so that periodic screening can be done in patients undergoing antitubercular treatment. Limitations are small sample size and number of follow-ups were limited. These are my references. Thank you.
Thank you. Will you please show that OCT picture again?
Yes.
Both sides, you have shown. Yes. That is normal.
Yes, sir. This was taken before the treatment.
Okay. Yeah.
Then after undergoing ATT, post 3 months, it showed significant thinning of RNFL.
Which quadrants he has written, no?
Yes, sir. In the left eye, temporal quadrant, right eye, superior, temporal and inferior quadrant thinning is seen.
Okay. Okay, thank you, ma. Thank you.
Changes?
Ma'am, visual acuity, among the sample size, it was not seen statistically significant, but those patients who were complaining of defective vision, when we checked the OCT, they had more RNFL thinning when compared to the other subjects.
So what is your line of follow-up when you find RNFL changes in those patients?
If RNFL thickness is seen to be reduced, we
you stop it?
Yeah, we asked to change the drug, ma'am, ethambutol. We asked to change the drug from the fixed drug combination. We asked to change the drug to other less toxic drugs.
After
So we follow up in the pulmonology department and we change the.
After the less toxic drug has been introduced, what happened to the nerve fiber layer, thickness and all?
What's that?
You have stopped the drug.
Huh.
You have started some other drug.
Yes, sir.
I will follow the patient afterwards.
Not all patients I was able to follow up.
Did they show any improvement or arrest of that particular changes?
Sir, some patients it showed improvement, not improvement like very little improvement and or arrest. But in some cases in the previous studies which I have referred, they have told sometimes even after stopping the drug there can be worsening of the toxic effects in